cardiology, what?
3?
This is our
Third time.
What was the first 2?
First ones? Yeah, and then musculoskeletal.
Oh, okay, cool.
There you go.
All right.
Well, he's back again now for ER.
We're so memorable.
Go over the differential diagnosis.
Okay, we'll try to get through this first part quickly, and then I have some case presentations. Have you guys been told about this lecture at all?
You told us.
Good, okay, I don't like people who know about it.
Do you want us to not record it?
At OU.
Do what?
I shadowed it at OU.
Okay, well, the cases have changed, so you can't, don't give anybody any hints. Basically, I'm going to go through a quick kind of synopsis on developing differential diagnosis in the ER and a few special tests. Yes?
All right, since you're doing cases, do you not want this recorded? Because we are recording.
No, I don't care if you record, it's fine.
Okay.
Just don't pass it along to the next classes, because I don't change them up that much and it kind of defeat the purpose. All right, so let's just jump into it. This lecture isn't, we'll get some test questions from it. It's not necessarily going to help you pass boards too much, although there is some great pearls in there. But this one's more or less to prepare you for clinical rotations. Caveat to this is designed for the emergency department, but I think it can be used in other fields. So, hope you guys know what a differential diagnosis is. Okay, thank God. It's how we get the list of possibilities for a given complaint. So this chief complaint looks like chest pain. How do we get from all the, oh God, well, that doesn't work either. Whatever, I'm not going to use a pointer unless I need to. How do we get from all of that stuff right there, the possibilities of a chest pain complaint, MI, aortic aneurysm, CHF, cough, whatever. How do we get from all those possibilities down to a diagnosis of pleurisy cough? Well, developing, we use a differential diagnosis, so it's a big list of possibilities of what something could be, and then we use different things to get it down to what it is. I like to use a two-tiered diagnostic approach in the emergency department as far as the development of my differential diagnosis. Tier 1 is most common, most likely, and Tier 2 is most deadly, most debilitating. So whenever I'm thinking of disease processes when I walk into the ER with a patient, the first thing that hits my mind, Tier 1, Tier 2 is not, they're not building upon each other, they're side by side. So these are equal importance. So whenever I walk into a room, my first thoughts are Tier 2's most deadly, most debilitating. What is going to cause this patient to A, die or suffer some irreparable harm that they're not going to be able to come back from? And then 2, what is the most common diagnosis? What's going to be the most likely reason that they're coming in? If you guys heard that old adage, when you hear hoof prints, think horses, not zebras. You guys haven't heard that before? Yeah. So basically just telling you, think for what's most common. A headache is a headache, not a brain tumor. Nausea, vomiting, diarrhea is gastroenteritis and not, eosinophilic colitis or some kind of carcinoid tumor syndrome or whatever kind of crazy zebra you can get out of it. And then we get to most deadly. This is probably one of the more important areas that I tend to focus on. Chest pain, are we going to miss, an MI, a AAA, pneumothorax, back pain, cauda equina is a big problem, or a big thing there. It's not very common, so that doesn't hit your Tier 1, but it is an irreversible loss of neurological problems that if you miss, you get your pantsuit off for. So saddle numbness, paresthesia, loss of bowel, bladder, tongue, all of this stuff in here should be a review. If it's not, let me know. We can discuss it a little bit more in detail here. Headache, stroke, meningitis. These lists is obviously not inclusive. This is just kind of brief things we're talking about. So how do we narrow down your list of possibilities? Well, we narrow them down by using all the tools we have at our disposal: history, physical exam, epidemiology, labs, presentation, etc. I always tell students that patients are a puzzle, and everything you have is a piece of the puzzle, and one piece of the puzzle does not complete the picture. So just the history does not complete the picture. Just one lab does not complete the picture, and not one physical exam finding completes the picture. So it's a puzzle. You got to use all your pieces to fit them together to get a result. And so I see a lot of times students will focus in on one thing in particular, and they miss a lot of other things that are screaming to go in other directions. And I think later on I may give the, we should do the cognitive biases lecture that talks more about that, if we give that lecture or not. If we don't, I can send it out to them. It's not, I mean, anything super special, but it's interesting. Okay, I added this into there a couple of days ago. I felt that this was helpful in creating a differential diagnosis. Have you guys ever seen this mnemonic, Vindicate? So this is a good mnemonic that we teach students in the ER, me and Kevin, whenever we rotate. It's a mnemonic to kind of help build differential based on presentation of symptoms. So, you know, your chief complaint is headache. We'll just say headache. This mnemonic helps build disease processes that you don't have kind of floating in your mind. As you're a student and as you start progressing in your practice, the more and more you become exposed to different diseases, the more and more you'll have them on the top of your mind. It's kind of like a chef. You first learn how to make, you know, soups and stocks and whatever. You're not, you know, you don't have the recipes for anything fancy yet because you haven't been exposed to it. So as you go along, you start to develop more of those fancy diagnoses you have rattling around in your brain. But early on, it's harder to figure those out if you don't know. So we use this mnemonic to kind of help get us to that point. So headache, vascular. So what would be some causes of a vascular headache? Yell them out, can't hear you. Templar arteritis, okay. What else?
Hypertension?
Sure, we'll call that vascular, yeah. Migraine, I think, would be more, yeah, it's not all inclusive on here. Subarachnoid bleed, stroke, okay. What about infectious? Meningitis, you know, any kind of viral infection can cause you a headache. Neoplastic, brain tumor, I mean, that's pretty simple, brain tumors. Degenerative, oh my God, there's an error in there. Yeah, that's not a special word. It's supposed to be degenerative. And that, I don't know how that. Degenerative process, I mean, there's not going to be a whole lot of, you can have some degeneration of brain cell matter and stuff like that just due from old age and things like that, but that's not necessarily going to cause you.
Degenerative discs in your cervical spine.
Sure. Iatrogenic intoxication, I mean, there, you know, other problems that we give them, congenital malformations, autoimmune diseases that can give you headaches, traumatic endocrine metabolic. This is not this is not going to give you the 100% accuracy that you have, but this is going to help create that differential if you're trying to figure out where exactly to go from. Use this mnemonic and try to think of different problems. So that'll get you the list, and then now we use our other tools at our disposal to cancel things off on that list. Okay, exam findings. All right. Why do you guys think I put vital signs 3 times up there?
It might be important.
Might be important. And dear God, I'm not kidding. Every single one of you that rotate with me will come up here and will miss it. They will be presenting somebody with chest pain. I'm like, okay, well, what's their heart rate? What's their oxygen saturation? Didn't like that. How are you going to develop a differential? What's the difference between somebody who has a cough and chest pain who has stone cold normal vital signs versus cough and chest pain who's satting 87%, has a heart rate of 130, and is breathing 30 times a minute? Do you think there's a difference in your diagnosis or your differential between those two based on just a couple of vital signs? Yeah, so you need to know your vital signs before you're developing your differential. And I mean, this is probably the 7th or 8th time I've given this lecture between here and OU. And every single one of you guys are going to come up here and you're going to miss it. And I'm going to yell at you, so just,
Take it.
yeah, just take it. It's going to happen. So, but try not to make it happen. Maybe be the first person that doesn't let that happen too. Maybe that's not going to happen, but try. Pay attention to your vital signs. And accuracy of vital signs is also important too. sometimes it depends on your nursing staff and how much they take attention to obtaining accurate vital signs. A lot of times these vital signs are done by a tech that has zero formal training, that maybe has a 6-week course or something like that. And I'm not trying to knock nurses or anything or the techs at all, but the validity of vital signs are important, and they're missed or overlooked by the people who routinely take them often because they are so routine. They kind of get in this kind of cycle where that's one thing that we do on every single patient, so they just go and run through the motions and don't really care about the accuracy of them. So getting somebody's heart rate when they just walked half a mile from the parking lot to sit down in your triage chair and their heart rate's 120 times a minute versus when you're actually sitting down and it's really only 90. Accuracy of vital signs, looking at your pleth for your pulse oxes, and making sure your blood pressure cuff fits right and all that other stuff. I mean, there's so many little things that can play with that. Exam findings, I mean, I'm not going to go over this too much in detail. I mean, you guys know, wheezing, think asthma, COPD, Rales, pneumonia, CHF, abdominal tenderness, where, how painful, quality, how is going to help figure things. Is there either protuberant, do they have ascites, is it distended from small bowel obstruction, you have hyper and hypoactive bowel sounds with necrotic tissue there. So physical exam findings, one piece of the puzzle. Epidemiology, so we try to use epidemiology as best we can to help kind of rule in and rule out certain disease processes. Pyloric stenosis, so most common in what sex and what age? Oh God, I have it right there. You guys could have answered that. I'd be like, man, good job. You remember that. So anyways, yeah. Most common in males, ages 3 to 5 weeks, uncommon after 12 weeks. So you get a 6-month-old in here, and they're, every mom that comes in at 1 o'clock in the morning says their child's vomiting, they are having projectile vomiting. It's vomiting across the room, it's going 27 feet, hit dad, through the walls, whatever. But you're like, okay, well, 6 months old, you hear projectile vomiting, it's easy to clue in on pyloric stenosis because, that's what we teach you and that's how you're being trained. But, 6 months old, it's not pyloric stenosis. Very uncommon after 12 weeks, and that's how we use some epidemiology to help figure these things out. Intussusception, the same thing, figure out the time frames when it's most common. MIs, we use different scales like heart score, TIMI scores, risk stratification scores to help kind of point us in the right direction and give us percentages and help us risk stratify those patients. That's based on epidemiology as well. Throat pain in the elderly, it's, a lot of times it's not strep, it's either viral or cancer or something like that. Lab, so this is what we do in the ER. We lab people up, for better or for worse. I can stand up here and lecture all day about ordering superfluous tests, but I do it every day, and you get mad at yourself, but that's just what happens there. Litigious nature of society kind of forces us our hand in doing such thing. So if you're going to order a bunch of tests, you know what to order and how to interpret them. So talking about CBC, so common errors in the interpretation of the CBC. So list me off a few things, non-infectious regions that will cause an elevated white blood cell count. Stress. Steroids. Medications, what medications? Other than steroids.
It's kind of like the weird immune ones that we're never going to prescribe.
Sure, some autoimmune things can cause an abnormally low white blood cell level. What other common medication will cause your white blood cell level to increase? Other than steroids. Albuterol will cause your white blood cell level to decrease. Albuterol causes white blood cell demarginalization, so it releases the white blood cells from the endothelial lining of the vasculature and causes an abnormally elevated white blood cell count. So you get your asthmatic kid in there, he's taking 1 billion puffs on his inhaler and had 50 breathing treatments, and then you decide for whatever reason to get labs because you really don't need to. But you get labs and they have a gigantic white blood cell count, but you can't really find a source of infection. Probably the reason why is from the albuterol. Key in on your shifts, your neutrophil counts, and your segs. Have an elevated white blood cell count with no left shift or no preponderance of band cells or neutrophils, likely not an infectious reason. Probably look for more iatrogenic causes, such as medication, stress, etc. White blood cell count is not diagnostic, it is supportive. Just because they have an elevated white blood cell count does not mean they are dying from an infection and or have an infection. It is a piece of the puzzle. It's supportive. I yelled that at you for a reason, because you're going to come back and be like, oh my gosh, your white blood cell count is 17,000. Okay, what else is pointing towards infection? All right, BMP versus CMP. What's the difference between those two? Liver enzymes, good. Determine bicarb and pH from this. How do we do that? Roughly. Rough estimate of pH. You can't determine a true pH from a CMP. CO2. Your CO2 is going to be the same as your arterial bicarb on your BMP. And you can get a quick glimpse at a metabolic acidosis based on your CO2 level. It is bicarb, same thing. So getting that, if you don't routinely, if you're not ordering a VBG or an ABG, and you see somebody has an abnormally low bicarb, high anion gap, that'll clue you into there's some kind of acid-base disorder going on there. So a lot of things can be gleaned from a BMP, a simple routine test that has 8 different things on there. You can get a lot of diagnosis from one test, and that's it. Anion gap, oh, look, I think it comes on there a little bit. At least I can see it. Can you see it? Whatever, I can see it, so. Anion gap, so you guys know mud piles?
And there's a
Yes,
cat
good.
too or something.
You guys know, okay, what, in mud piles is good. We do a little bit more called A mud piles cat, adding the A at the top, CAT at the bottom. You guys heard that one, good. That one's a little bit more inclusive though. I mean, if anybody in here sees a true case of cyanide poisoning, that's pretty cool because that's really never going to happen. Or some kind of toluene, somebody's drinking paint, some kind of weird paint additive. Those usually don't happen too much. Yeah, syphilis, yeah. So, I mean, those are good to know. And I'm going to pimp you guys on it when you come in, so you better know it when we rotate, because we use that a lot. Urine, get a pregnancy test on women. Tubal ligation is not definitive. Cardiac biomarkers, TROP, CK, CKB, myoglobin. I don't think I did a cardiology lecture for you guys, did I? I did? Okay. Good. So, go over those. Know when they peak, how long they persist. You should know them if you pay attention. PT-INR, know what's therapeutic for which conditions. What's the therapeutic INR for somebody that has a artificial valve versus somebody who's getting prophylactic treatment for a DVT secondary to hip surgery. Know the difference of those. D-dimer, know your specificity and sensitivity of that test. It's not a great test, although I am using it more here recently. The more and more I read and kind of the research on it, there's a lot of good algorithms that we can discuss at a later date on using when to use a D-dimer, who to use it on, so we can decrease the amount of radiation exposure for people and save them from getting a CT of the chest. It's always kind of a roll of the dice. It's tons of positive D-dimers and negative CT angios of the chest. But if you can get it to be negative, that's good. A lot of people won't run it. There's a lot of ER physicians and stuff like that. My previous place I worked, Mercy Oklahoma City, they never really ran D-dimers. They just did straight CT of the chest if there was any kind of risk for pulmonary embolism. But I think more and more research talking about cancer and stuff from the CTs, you should be a little judicious about it. Diagnostic predictors and tools and risk stratification tools are very helpful. Know all of these. I mean, maybe not for your test, but when you come to work in the ER, I'm going to pimp you on every single one of these things. These are going to help you know when and how to do things. P-card score for whatever you need to CT some kid's head. Centaur criteria for strep. Wells DVT and PERC rule for pulmonary embolism. We don't need to run a D-dimer if their PERC rule's negative, right? Because there's like less than a 1% chance that they have a PE. PERC rule's an easy thing to document and say, hey, we're done. PE is no longer on the differential. Nexus criteria for CTing somebody's neck, when to image it after trauma. Same thing, the Canadian CT head rule. Wesley Cruz score, I think if I did the bronchitis lecture, that's important about when and where and how to treat them. Heart score, TIMI score, I like both of those. I use them a lot. I use heart score more than I do TIMI, but I think both are good, helpful tools. So talk a little bit about special tests here, stuff that we may not do so much in lab medicine. Procalcitonin, helpful in differentiating between bacterial infections versus viral, helpful in sepsis. There's conflicting research on it. Some say that procalcitonin is, doesn't really point you in any really good direction. If somebody has an elevated procalcitonin, that you're thinking, leaning that, hey, this patient might be septic. Well, yeah, they have double pneumonia and their pressure is 70/30. I didn't need a procalcitonin to tell me that. So there's a lot, the research is conflicting. I use it sometimes. I ordered a lot for hospitalists and not for myself. Hospitalists will use it if you have a chest x-ray that looks a little fluffy, trying to figure out whether this is an infiltrate or pulmonary edema. They may have a slight white count, but they have a history of congestive heart failure. We're trying to figure out whether that's a bacterial infection versus just a vascular congestion, and that's going to be helpful to figure that out too. SED rate, CRP, I honestly think they're worthless tests. There's a few diseases that are very specific for numbers regarding that. But I know our hospitalists love CRP for some reason. They're like wanting to get it on everybody. It does me in the emergency department absolutely zero good, and I think it's a very non-specific inflammatory marker that doesn't really tell you a whole lot, but some people want to get it. What can you think, what is a disease process that just bounced off the top of your head that you would need one of those two to confirm? Do what?
Rheumatological diseases like ankylosing.
Okay, so if you had elevated CR, does that mean you absolutely, or CRP, does it mean you absolutely have ankylosing spondylitis?
No, it's just
No.
helpful for the diagnosis.
Sure, there are more, I think there's more specific inflammatory markers for ankylosing spondylitis. Is that HLA-B27 or something like that? I feel like that's routing around some of my brain. What's another one? Templar arteritis. Have to have an elevated SED rate to have templar arteritis. So there are a few septic arthritis. You need to have, you don't need to, but it's good to have an elevated SED rate to help support that. Rheumatological disease or autoimmune disease flares, you're going to see a bump in that, but not necessarily specific for one specific thing. Beta hydroxyketones, serum ketones, know your ketogenic conditions. Urine electrolytes helpful for hospitalists and ICU to see where you're losing those electrolytes from. Don't forget to get that. That's a nice thing to get so that they can kind of help make those decisions. Not really going to help you a whole lot in the emergency department, but if they're peeing and you get a UA, might as well get it now versus they'll have the hospitalist wait 7-8 hours for them to pee again in order to get it. So ABGs, easy one to forget. A lot of things can cause acid-base problems. A lot of subtle findings can be caused from gas exchange problems, so don't forget about that. VBG, I need to add something to there. VBG, I use venous blood gases more often now than I do arterial blood gases. I think they give you an accurate display of pH, bicarb, and PCO2 in most conditions. Bicarb is gonna be spot on. pH is gonna be a little bit off because it is venous, but there's good calculations on how to extrapolate the what's positive, the range, normal range. What's acidosis and what's alkalosis on the range. There's good figures for that. It's not the exact same as the arterial. But it's easier. You don't have to poke somebody in the wrist, in their artery. You get it from a regular blood draw. I use that quite a bit. The only thing what's the only thing you wouldn't get an accurate measurement on for ABG versus venous blood gas?
Oxygen.
Oxygen. So if you have an accurate pulse ox, an accurate SpO2 on your pulse ox, that will take the place of the oxygen tension for an ABG. We can use that, what's it called? What's the graph where it shows you what your percent SpO2 is as related to your oxygen concentration? You know what I'm talking about? Looks like that. What's it called? You guys are supposed to know this. I probably
That's
should
next
know it.
lecture right after.
Yeah.
this, actually.
There we go. And ammonia, I don't know why that's cutting off there. That's weird. Is it cutting off for y'all guys?
No, it doesn't.
The
Okay,
oxygen
good.
unit moving to
Um,
dissociation.
On our computer, they've got it on their computer.
Okay, cool. So ammonia levels, don't forget about that. Liver failure, encephalopathy. Somebody comes in, they're acting weird, looking weird, maybe be a little bit yellow. Don't forget the ammonia levels. Hemoglobin oxygen saturation curve. Well, I think that's like kind of a no-brainer. I think we said all those words while we were trying to figure out the name of it. Yeah. Okay, radiological imaging, when to image somebody, when to do a CT of the head, PCARN rule, Canadian CT head rule is going to help you figure that out. You know, if in doubt, no one's going to burn you on it. It's the least amount of radiation you can have out of all these CAT scans. It's quick, it takes 10 seconds, you know, not a big deal. CT abdomen pelvis, so with and without contrast, oral contrast, rectal contrast, know when and where you would want to give those. Kidney stones, you'd want to do no contrast, right? It's a myth that you're not going to be able to see kidney stones on a CT with contrast. You absolutely still can, but you're going to miss smaller kidney stones. But you can still see kidney stones even with you give contrast. But you will miss the smaller ones, and the imaging sections are not as thin whenever you do a CT without the stone photochrome.
More so the reason you don't give the contrast, because if you give IV contrast, it has to go through the kidneys to filter, and if you've got hydronephrosis or a decreased function of that kidney due to a prolonged kidney stone that's backed up and causing a dysfunction, then you could possibly cause more damage to the glomerular.
Sure. And that's why we do
That's
this,
the real reason why you-
get a creatinine level too. But there's a lot of new research on contrast nephropathy coming out, and we are finding that it's not as big a deal as we think, and that contrast nephropathy is really not being caused by it. The American College of Emergency Physicians, I think, had one that came out this year. I'll email it to you guys, talking about contrast nephropathy and about how there was really no correlation between giving the contrast and acute kidney injury, even in patients that had an abnormally elevated serum creatinine level. Interesting stuff. CT neck, cervical spine, nexus criteria. Old person C-spine x-rays are worthless. They got so much arthritis and junk in there that you're not going to be able to see anything. Just get a CT of the neck. In trauma, CT of the neck is replacing your kind of stereotypical cross-section table C-spine image that you used to get in the old ATLS. Some of the trauma centers will still do it with your typical, chest, pelvis, and then a cross-table C-spine x-ray. But, CTs of the neck are going to be more sensitive to your subtle osteo injuries. And don't forget, you can get them without contrast and look for soft tissues. It'll be helpful in finding esophageal foreign bodies. Angiograms, CT, the head and neck to look for vascular pathologies, and stroke are also important too. CT the bones, don't forget you can CT bones too, looking for subtle breaks, dislocations, things like that. You get an x-ray of somebody's pelvis, hip, or whatever, and you're like, man, that looks a little weird. I don't know, maybe it's, it's not quite, broken in a billion pieces, but something just doesn't look right. And you get them off the table and they're still hurting really bad. CT the bone, CT that hip, CT the face, looking for facial fractures. Don't forget that you can look helpful in determining that. I always will, get a CT of an extremity for somebody who presents with a trauma that is still unable or unwilling to either ambulate or move range of motion of the joint without extreme pain. So if somebody comes in, says they twisted their knee, x-rays look stone cold normal, but when you try to get them up in a brace or even move their knee, they're just jumping off the table, they're freaking out anytime you touch it, even after pain medication. I will always get a CT of that joint to look for any kind of subtle break. You can find all sorts of tibial plateau fractures and things like that that are more apparent on CT. So most of the times I use them for knees and hips, so kind of help tease out those subtle findings. CT the chest, when you use with and without contrast, questionable X-ray, used for questionable X-rays, PE evaluation, what's the gold standard for diagnosis of a PE?
CT angiography.
Exactly, it's gonna be a board question. Did I already ask that?
No, they were just giving that last lecture, but still.
Okay, good, yeah.
They got it.
Good, get it, because you're gonna be asked about it, I promise you, it's gonna be a board question.
You guys got it now.
Yeah.
Good job.
MRIs, don't use them a whole lot in the emergency department, but they do have some times when I would get them, strokes, differentiating a stroke. Sometimes I'll get it out there in Logan County because, we do like 2 MRIs a day outpatient, so we have an MRI tech there the whole time, and if you're not busy, you can. In bigger emergency departments, that's common. You don't get a lot of MRIs. Cauda equina is helpful to diagnose that. You need an MRI to diagnose that, can't do CT. Any kind of epidural abscess or any kind of epidural hematoma is helpful. Somebody presenting with, unilateral, bilateral paresthesias, muscle weakness, something like that. They're IV drug user. You need to, CTs can see them, but just not as good as MRIs. So they would definitely need an MRI, cervical, thoracic, lumbar, to see if they have any kind of epidural abscess, epidural hematoma. Yes?
Can you see a PE on a CT with just like chest CT with contrast versus like a PE protocol CT?
Yeah. The only difference between the two is the angiography. It's a computer program that formats the images so that you can see vascularity better. But we don't have CT angiography at Logan County. We just have CT with contrast and without. And the supervisor for the RAD department was telling me that there's really not a big difference. The only thing is you don't get those reconstructed vascular images, but you absolutely can.
So I know I used to do CT and Craig, and they don't have the angiography either, and we had a specific PE protocol where you have the bolus of the aortic. Can you still see it from something if you're not doing that protocol?
I'm pretty sure that protocol is helpful because that takes the images at the right time the contrast is going through there, but you're still going to have some residual contrast through those vessels anyways. You can still see it, but maybe not the best way. And you may miss some small, subtle, tertiary pulmonary embolism that you're going to probably send home anyways. There's new literature out there saying that if you're not hypoxic and you're breathing, you're breathing just fine, they send secondary and tertiary and some secondary pulmonary emboli home on just some oral anticoagulation and say follow up. Don't even admit those people. And I would think that if you had a gigantic saddle emboli, that you'd be able to, a radiologist would hopefully be able to see that with contrast. But if you don't have contrast, then you're not going to be able to see it. Contrast is helpful in two things with chest: aortic dissection and pulmonary embolism. Those are the two that you're absolutely going to need to have contrast on them to diagnose. If you don't have contrast, there's no way you're going to see it. Now you can see some aortic distension or volume changes or dilation on a CT without contrast, but you are not going to see the dissection because you need to see that contrast layering out between the intimal layers in order to do that. Radiation risk, we talked about that. It's a real thing. Don't hand scan everybody just because you're worried about getting sued. Be judicious about it. I don't have a problem with you guys ordering CAT scans. Have a good reason for it. Okay, is everybody cool with that? Okay, let's take a quick 5-ish minute break, and then we're going to get into our case studies. The way we're going to do these cases, we'll kind of work through slowly the first one, and then the last 5, you're all going to do them. I'm not going to say anything. Is I'm going to present you with a clinical vignette and all the information that you would need to, develop a differential diagnosis. And then I'm going to come up to the board. I have a list of lab results here. And you guys are going to order tests. I'm going to give you the results. You're going to make diagnoses and order treatments based on those figures. So let's take a break and then we'll get into it.